Urologic Symptoms by Dr. Amr Hassan Abu Faddan. In this lecture, we will discuss about your upper urinary tract symptoms, lower urinary tract symptoms, which is LUTS, urinary changes, male genital symptoms, uremic manifestations, extra-urological symptoms related to the urologic disorders, and asymptomatic cases in urology. This is another chart can classify the urological symptoms, maybe urogenital symptoms and general symptoms. The urogenital symptoms in the form of pain, voiding dysfunction, changes in the color characters of urine, swellings, discharge or fistula are symptoms of the chronic kidney disease. Male genital symptoms are in the form of erectile dysfunction, ejaculatory disorders, hemospermia, Peyronie's disease, priapism, and infertility or subfertility. The other classifications or the other way around, the female genital symptoms and systemic or general symptoms related to the urological, gastrointestinal, neurogenic, vasculogenic, congenital or metastatic.
بقعد كده اشوف السلايد دي قد ايه وبسجل البتاع كأنها.
وانت مش سجلته؟
انا سجلت الصوت، فاضل انها تبقى فيديو.
نعمله ازاي يعني؟
ما هو ده اللي بعمله دلوقتي. بخلي كل سلايد بشوف.
طب انت هتشرب ولا خلاص كده ولا ايه؟
ما جنبي.
طب عشان بقى 10 دقايق.
حاضر.
The upper urinary tract symptoms in the form of pain, renal swellings by examinations, oliguria and anuria, polyuria, and discharge. In this slide, we will discuss about the general concepts of pain. The pain within genitourinary tract usually arises from the obstructions or inflammations. Referred pain may be common. Acute inflammations of the parenchymatous organs produce severe pain and high-grade fever. For example, pyelonephritis, prostatitis, epididymolysis. Usually, the tumors does not excuse or don't cause pain unless they produce obstructions or extend to the adjacent nerve. So again, what are the types of urogenital pain? Renal pain, ureteric colic, bladder pain, prostatic pain, penile pain, testicular pain, and urethral pain. The first types of pain is renal pain or flank pain, which is a visceral pain, arises from the obstruction and distension of the renal capsule, which is dull aching pain and steady pain, arise from the posterior renal angle and radiating anterior toward the umbilicus, may be associated with the genitourinary symptoms like nausea and vomiting. The differential diagnosis of this pain may be arises from the musculoskeletal or gastrointestinal, gynecological, herpes zoster, basal pleurisy, and pneumonia. The second type of pain is urethral colic. It is a hyperperistaltic and urethral colic, which is colicky in nature, intermittent, and occurs in waves. The most severe pain humankind can experience, associated with the restless, nausea, vomiting, sweatings may be associated also up to collapse. The fever and the chills, hematuria may be exist, aggravated by the jogging movement, the renal pain due to the distension of renal pelvis, the site of the maximal intensity varying according to the site of the obstruction. The urethral colic arises from the costovertebral angle, radiates to the lower quadrant of the abdomen, anterior aspect of the upper thigh and testis or the labium. The middle ureter simulates appendicitis or diverticulitis. The lower ureter associated with the suprapubic discomfort with vesical irritability like urgency, frequency, radiates to the along the urethra to the tip of the penis. The third type, bladder pain or suprapubic pain, may be severe bursting pain in the acute urinary retentions, burning pain relieved by the voiding in the case of the cystitis, or sharp stabbing suprapubic pain at the end of the micturations, which is termed strangury. The fourth type, prostatic pain, localized to the perineum, referred to the lower back and rectum. The fifth type and the last type is urethral pain, which is burning or scathing pain in the start of the micturation. This is due to the urethritis or the urethral stones. Now we will discuss the very important and hot topics, which is oliguria and anuria. The oliguria is defined as the urine output less than 1 milliliter per kg per hour for the infant, or the half milliliter per kg per hour for the children, or 400 milliliters per 24 hours in the adult. The anuria is defined as a cessation of the urine production resulting in the output or urine output less than 100 per milliliter per 24 hours, which means acute renal failure. So, what are the causes of the anuria? Maybe pre-renal, intrarenal, or post-renal or obstructive anuria. The pre-renal causes lead to the hypotension, hypovolemic shock, decreased renal perfusions, decrease of the glomerular filtration rate, and acute renal failure. The intrarenal causes lead to the acute tubular necrosis oliguria with proper management. Recovery occurred within 2 to 3 weeks. The post-renal, which is very important to our department, the post-renal causes of the anuria or obstructive anuria. Please don't forget, both are equal. Bilateral obstructed kidneys equal obstructed only function kidney. The very important topics is post-renal or obstructive anuria. This is the surgical problem entailing complete and bilateral urethral obstructions or complete obstruction of the ureter of the solitary kidney. Please remember the urinary bladder is empty, the circulating volume is overloaded, the serum creatinine is rising, and electrolyte imbalance will be occurred. Causes of the obstructive anuria. The most common cause is stones, which is called the calcular anuria, may be your bilateral ureteric stones or bilateral renal stones. The second cause is malignancy or advanced malignancy infiltrating or compressing the post-ureters, leading to the obstructions like prostate cancer, bladder cancer, cervical, and rectosigmoid cancers. The third type is surgery or iatrogenic bilateral ligations of the ureter during hysterectomy or abdominoperineal surgery. Retroperitoneal fibrosis and bilharzia ureteric strictures are causes also. Polyuria. It is excessive production of urine to more than 3 liters per 24 hours in adult, result in painless frequent micturition. The volume of urine per void is normal or even increased. It caused by diabetes insipidus, diabetes mellitus, chronic renal failure, post-obstructive diuresis, increased water intake, and diuretics. Lower urinary tract symptoms or LUTS may be classified according to the storage symptoms, which is irritative LUTS, voiding symptoms, which is obstructive LUTS, pain, which is previously discussed, urethral discharge, swellings, or lower urinary tract fistula or sinuses. Now we will discuss storage LUTS or storage lower urinary tract symptoms, irritative LUTS or irritative urinary tract symptoms. This caused by irritative bladder pathology like bladder stones, bladder ulcers, inflammations, diverticulum, or bladder cancers. This is characterized by increase of frequency of micturations more than 8 times per 24 hours, or nocturia or nocturnal frequency, which is micturate 1 or more time per night. Urgency, which is a sudden, severe, compelling desire to micturate that cannot be deferred. Urge, incontinence, involuntary leak of urine associated with urgency. Voiding lots or obstructive lower urinary tract symptoms may be hesitancy, which is difficult to start of micturations, or intermittency, which is micturating with interrupted stream, weak stream or narrow stream, which is narrow caliper, straining during micturation, terminal dribbling, sense of incomplete evacuation of the bladder, or acute urinary retention, which is a maximal form of obstructive LUTS. Urethral discharge. This is a urethral discharge not related to the act of the micturition and detected in the clothes of the patient. The amount, color, associated symptoms must be assessed to give the clue of the diagnosis. The discharge may be mucopurulent or mucus or purulent discharge in the cases of the urethritis, urethral diverticulum, or urethral discharge around the fixed urethral kysta. May be from the seminal vesicles due to the prostatic congestion, prostatitis, or the sexual excitation. Blood, which is very important, which is termed bleeding per urethra, which is the main cause of urethral trauma. Suprapubic swellings mostly due to the chronic retention. Perineal or penile swellings due to the urine and or blood extravasation after urethral trauma or penile fracture. Lower urinary tract fistula and sinuses. The cause can be congenital, inflammatory, or post-traumatic, accidental or surgical, or neoplastic. This classified our vasicocutaneous fistula or suprapubic fistula, vasicovaginal or vasicorectal fistula, or uretrovaginal fistula. Uricus, which is congenital umbilical vasicocutaneous fistula, or urethrocotaneous fistula, perineal or penile, uretrovaginal or uretrorectal fistula. Acute urinary retention. It is a sudden, painful inability to pass urine in spite of severe desire to micturate with full bladder. The causes of acute urinary retention: stone impacted in the urethra or bladder neck, urethral trauma with complete urethral rupture, prostatic diseases like benign prostatic hyperplasia (BPH) and prostatic abscess, or neuropathic causes after spinal cord injury. Occasional causes of acute urinary retentions: reflex urinary retention due to severe painful perineal or anal conditions after surgery for piles or anal fissures, obstructed Foley's casters, acute urethritis, phimosis, and psychological retention. Now, how we can evaluate the patient with acute urinary retentions? By the history, clinical examination, and investigations. As regarding to the history, inability to micturate with spite of the severe desire of micturations with agonizing suprapubic pain. History suggested the cause: recent renal colic, migrating stones. Old male, maybe BPH, recent surgery in the anal or perianal and spinal surgery. By clinical examinations, the suprapubic fullness, tenderness, dullness without palpable suprapubic mass. A palpable bladder means acute on top of chronic urinary retention. By digital rectal examination may be show stone at the membranous urethra, prostatic tenderness means acute prostatitis, PPH, tender cystic bladder on the bimanual examination. As regarding to the investigations like abdominal ultrasound, confirm the bladder fullness, maybe detect bladder stones maybe in the pictures, or detect of clots in the bladder, which is called clot retention. Differential diagnosis of acute urinary retention: clot retention, chronic retention, and anuria. The clot retention: in cases of the massive hematuria, the bladder is full of urine and blood clots. Chronic urinary retention: although the patient is voiding, the bladder is still distended and palpable without pain or tenderness, which is gradual increase of the residual urine. The patient may develop acute on top of chronic retention. Anuria: no desire of micturition as the bladder is empty, with risk and signs or symptoms of auremic manifestations. This is very important. Tables show the difference between the acute urinary retention and obstructive anuria. As regarding to the desire of micturations, is present in the acute urinary retention but not in the obstructive anuria, although the suprapubic pain. However, the renal pain is present in the obstructive anuria but not in the acute urinary retention. By examination, general examinations, in acute urinary retention is agonizing and pain, and obstructive anuria there is maybe uremic manifestations. By abdominal examination, the very important to put in your mind that the bladder is full in the acute urinary retention, however is empty in the obstructive anuria, and in the obstructive anuria also may be tender line. How we can treat? In the treatment in the acute urinary retention, urethral or suprapubic catheters. In the obstructive anuria, urethral catheters, double G insertion, maybe need ureteroscopy or PCN if the other manipulation is failed. How we can manage the acute urinary retention? The first aid is emergency relief of acute urinary retention by urethral catheter, which is contraindicated in the urethral trauma and bleeding per urethra, urethral stones, and urethritis. The suprapubic tube if the urethral catheter is failed, or insertion of the Foley's catheter under the general anesthesia by cystoscope. And the second line of the management is the treatment of the cause. Hematuria. It is a presence of more than 3 RBCs in high power field in the urine sediment after centrifugation. Classification may be classified as a microscopic or macroscopic, which is gross hematuria, according to the cause, systematic disease or urinary tract pathology. May be classified according to the relation to the micturition as a total hematuria, terminal hematuria or initial hematuria, the painless or painful hematuria. Etiology of the hematuria may be glomerular cause or non-glomerular causes like urethriasis or urinary tract stones, infections, trauma, PPH, polycystic kidney disease, or tumors. Post-operative, either urologic or in the open surgery or endoscopic surgery as a primary or reactionary or secondary hemorrhage. Coagulation and bleeding disorders or anticoagulant consumptions and anticoagulant therapy. Cyclic hematuria, which is bleeding or hematuria with the menstruations, may be mixed with menstrual blood is mixed with urine in the vesicular fistula or endometriosis of the bladder or the ureter. The evaluation of the hematuria by the history, examination, and investigations. As regarding to the history, may give a clue of the cause, like trauma, operations, or previous exposure to the bilharziasis. The relation of the hematuria to the active of micturations, which is very important, may be initial, terminal, or total. The initial, which is hematuria followed by clear urine. This is due to the lesions in the posterior urethra or bladder neck. The terminal hematuria, which is hematuria preceded by clear urine. This is due to the bladder lesions like bilharziasis. Total hematuria, the whole urine is red due to the bladder or upper urinary tract lesions. The color of the hematoric urine, the bright red, this means fresh bleedings, or brownish urine may be due to old bleeding. Presence of the blood clots confirmed true hematuria and may cause obstructive blots up to the clot retention. The shape of the blood clots, thread-like clots, are from the renal or urethral origin, while the discoid clots are mostly from the urinary bladder lesions. associated with pain help in localization of the pathology. The painless hematuria is present in PPH, transitional cell epithelium of the urinary bladder, or bleeding tendencies. Bleeding at the other sites suggests systemic causes. One of the most important differential diagnoses of the hematuria is a bleeding periurethra, which means the blood trickling from the urethra without voiding due to the urethral lesions or trauma to the distal urethra or distal to the urinary sphincter. The blood detected in the external urethral meatus and closes. The treatment of the hematuria entails the treatment of the cause and with measures. General measures in the massive hematuria control or treat the clot retention and the specific measures. The general measures in the bed rest, good hydrations, hemostatic drugs. In the massive hematuria, hospitalization is must, vital signs and blood transfusions must be done. In clot retention, 22 French Naloxone catheters should be fixed first, followed by using three-way Follis catheters for regular bladder wash. In specific measures is to stop the bleeding in as like hemostatic dose of the radiotherapy in the case of the massive bleeding from the bladder cancer, angioembolization in the renal trauma or renal tumors.